Hi everyone, this is the promised review for the next test, exam 2. We're going to start in chapter 18 and see where we can go from there. Alright, so you know your overview of chapter 18 is your anticoagulants and antiplatelets, iron preparations, folic acid and B12, things like that. The biggest thing that you're going to find too in primary care is Coumadin, and now Xarelto and Eliquis, things like that. You'll be responsible for dosing and monitoring of those things. The other classic thing that you'll run into is iron deficiency anemia, which is the most common form of anemia among this population in the United States. So those are things that you're going to have to learn how to manage and what you can give with what and what doesn't work so well. Alright, so let's start here with your review. So your anticoagulants, you know you have warfarin, heparin, your low molecular weight heparin, which is basically low molecular weight is your Lovenox. Okay. Alrighty. Okay. So warfarin, it's a pregnancy category X. If you have somebody that's got clotting problems, that's pregnant, you're never going to have them on warfarin. You're either going to have them on heparin or Lovenox. Lovenox is really not the preferred choice, although it is given. All right, and let's go to your next. Okay, so you have somebody that's on warfarin, and he's got some, not necessarily joint pain, just minor aches and pains. He's not that old, maybe. What are you going to recommend for him to take? You can't tell him to take aspirin, obviously. And you probably shouldn't be having him take NSAIDs either. So once again, whenever you have somebody who has who's on warfarin or a blood thinner, and they have some minor aches and pain, you always want to encourage them not to take ibuprofen, but the best way to use is acetaminophen. And for the exam, we're going to say not to exceed 3 grams daily for pain, but in real life, it's really not to exceed 4 grams rather for the exam, but 3 grams in real life is what you really want to do. Let's see. You also know that certain things with warfarin, there's a benefit to warfarin opposed to with like Eliquis or Xarelto. Eliquis and Xarelto, there's no antidote, but with warfarin, you know the antidote is vitamin K. So in the elderly, that's why I think a lot of physicians are more comfortable with warfarin, even though it can be quite labor-intensive to monitor Coumadin levels. So you have your patients who are on warfarin, and they're your elders, and their levels are up and down. It's best, we always tell them to avoid high vitamin K foods, not just vitamin K foods. For the exam, the answer will always be avoid high vitamin K foods. But in real life, once again, it's easier to have the patient eat whenever they want to eat and adjust the dose based on that as long as they're kind of consistent with their diet. Okay, let's see what we have next. Okay, so you know you have somebody who's gone into the hospital for a DVT, and you know they're going to have your bag of heparin hanging, and then they're going to start your Coumadin, and the starting dose of Coumadin is usually about 5 if they're a normal weight patient, and of course higher or lower based on weight, and maybe possibly lower based on age, but 5 is the general rule. So what you want to explain to your patient is that we're going to go ahead and start the warfarin while you're still on the heparin, and what you're looking for is the INR of 2. Once the INR is at 2, you're going to DC the heparin for the patient. Okay, so your most accurate draw for your INR is in the morning. And whenever you're writing your prescription, you want to write your brand name for warfarin, and then you want to always click the box, do not substitute. Okay, and we talked about the average dose already, starting at 5. And safest in pregnancy right now, as you can see, pregnancy C is your heparin, whenever you need that. Now you'll have people that are on heparin for if they have lupus anticoagulant or things like that. So there will be several women that you're going to run into that do take heparin during pregnancy. Okay. Well, other than that, that's the, whoops. Let's see if I can go back. and I was able to go back. So once again, heparin safest in pregnancy, low molecular weight heparin, Lovenox when you're pregnant. You want to draw for that factor XA levels. That's the take-home point of using low molecular weight heparin in a pregnant woman. Okay, so what are we going to monitor when you have somebody on heparin? You're going to monitor PTT, a platelet, and hematocrit every 2 to 3 days initially. So you have to remember, you have to keep close watch. Thrombocytopenia will actually not kick in until like the 4th day of therapy, and that is a kind of a common side effect. And I'm talking mild thrombocytopenia. I'm not talking platelets in the 30s, low hundreds, things like that. So it's something to be watched for, and it should also level off. The other thing I wanted to talk to you about too is you're going to have a lot of patients that are going to come in and tell you, especially elderly patients, we're flying to Hawaii. It's a long trip, we're going to Europe. How am I going to avoid getting a DVT on the plane? They worry about this, and they should worry about this. So you're going to tell them you're going to educate your patient on how to prevent, ways to prevent a clot. So you're going to explain them that, they need to get up every 30 minutes and walk around. Now I have heard of some physicians telling them to take a baby aspirin. I don't know that I totally go for that or not. Unless they're at super high risk of forming a clot. If they're just a normal patient that really doesn't have any risk factors, I don't know that I would recommend that. So basically you're going to give them the education, and there's actually pamphlets about how to avoid clots if you have no risk factors. Let's see, teaching patients about the risk of DVT prevention while traveling. This is this slide actually, sorry about that. And that's pretty much just it for all your Coumadin teaching, I think. I want to just make sure. Okay, let's click through. Aspirin, the difference between aspirin and warfarin. Aspirin is antiplatelet activity, prevents the clots that cause a heart attack, the sticking together. And that's similar to how Plavix works as well. But it inhibits the COX. So if you're giving other COX inhibitors, there's really not a lot of merit in that as well. Okay. So if you have somebody that comes in, that's what you're going to explain to them. You want them to take a platelet because it's got an aspirin rather, because it's got antiplatelet activity, and it prevents clots that can cause heart attacks. Okay. Here's all your antiplatelet drugs. Plavix is at the bottom. Aspirin is at the top. Those are probably your two famous ones. You need to know too that symptoms of aspirin toxicity when you're telling patients to take aspirin, and that would be tinnitus. Okay. There's a cross sensitivity with NSAIDs. That's another important thing. Okay, so there's adverse reactions to your aspirin. Bleeding is one. GI bleeding especially. And then of course toxicity starts with tinnitus. Plavix will cause bleeding. Once again, remember there's no antidote for Plavix. There's no antidote for aspirin either. And that's why warfarin is still used so readily. Okay. There's many drug interactions. Aspirin interacts with herbals, NSAIDs, Plavix with proton inhibitors. There's that cytochrome P2719 inhibitors, which I'm still going to talk about prior to your exam. Okay, so here's your dosing, your clinical dosing. So if you have somebody for MI prevention, AFib prevention, stroke, and TIAs, 75 milligrams of Plavix is pretty much your normal dosing. Okay. So you're going to discuss all herbal products with your provider before taking Plavix. And Plavix really does, has a significant antiplatelet activity. Even the fish oil will react with that as well. Fish oil and niacin are two that's in the blood as well. So you need to be careful. They can't be taken with Prilosec or omeprazole. And once again, they all cause bleeding. Okay, and then we're going to move on to EPO. EPO, Epigen, Procrit. This is something that I actually end up using a whole lot. Patients that are being treated with EPO need to watch for thrombocytopenia in them too. Now that can be not significant once again, like under 100, but you need to watch for the drop and make sure that it levels off. Any of these drugs, EPO, Neupogen is for your white blood cells. That's even more problematic. The patient feels like they can have some flu-like symptoms. They can feel like that with both of them, but more with Neupogen. So we're mostly going to talk about EPO in this lecture. This is a great drug to use when you have somebody who has stage 3 and 4 renal insufficiency. Those patients have a hard time maintaining hemoglobins above 8 a lot of times, and this is something that you can give once a week, 3 times a week, although it's extremely pricey, so you have to make sure that it's approved. Okay, it's given IM or sub-Q, and let's see. Can raise their blood pressure. I've not really had a problem with patients with that whatsoever. Like I said, these are usually your renal patients, and they may have some high blood pressure anyway. Okay, so seizures, hypertension, those are all your possible adverse effects. Okay, so EPO to treat anemia, it's 50 to 150 units per kg 3 times a week. So that's probably what you need to know for your exam, I'm sure. But here's the most important deal. It comes in 4,000, 5,000, 10,000, 20,000 units, and you kind of choose. You can base it on how bad your patient's anemia is, the weight of your patient, because it is an injectable, all different types of things like that, and also all your comorbidities that your patient has. So you can kind of calculate 50 to 150 units per kg, but usually in the long-term care facilities, when I have a patient, because it's so expensive, they'll only approve 4,000 units 3 times a week. And there is a stop limit. Hemoglobin of 10.5 is usually our stopping point. So whenever you have anybody on these, you want to do a full workup. You want to do your B12, your folate, your hemoglobin hematocrit, and you want to check for those renals and see what's going on. So I have your iron preparations. They have low iron stores, what's going on. Okay, so everybody knows the GI symptoms, constipation, GI upset when we're giving iron supplementation. Okay, so for clinical use, takes 3 to 4 months for hemoglobin and hematocrit to return to normal. Why is that? The life of a blood cell is 120 days. So it actually takes you that long to make a new one. Okay, so for iron deficiency anemia, adults are going to give 100 to 300 milligrams elemental iron daily. In a preemie is going to get 2 to 4 milligrams per kg per day. This is if they have anemia, all right, until about 12 months. And actually it's more of a preventative too, but I'll have something circled shortly, or in red. And you want to make sure to get enough vitamin C. You cannot take dairy products and calcium anywhere around the iron preparation because it just binds it. And that is that for now.